Hello everyone and welcome to episode 14 of Listen Up, Abbey Care Recovery's podcast. And today we've got Kirsten Horsburgh for the SDF here. Welcome Kirsten, how are you?
I'm good, thanks very much for having me. I can't believe it's only episode 14. I feel like I see this all the time popping up. Must be my algorithm.
Yeah, I'm glad you see it all the time. It must be getting watched out there. Only episode 14. And what we're trying to do is just get a variety of different guests on my show, you know, for all different kind of services in Scotland or people with lived experience in recovery and stuff like that. So I know you're a really busy woman and thanks for coming through today. You were unable to get into work because of the fire in Glasgow.
Yeah, that's right. Yeah, no, I really appreciate getting the invite to come on, so thanks. And yeah, really sad weekend for Glasgow with the fire. And our office is on Mitchell Street, so it's just sort of around the corner for that, and it's all still cordoned off. So
Thank you for coming
sad.
through. So Kirsten, you're the CEO at the Scottish Drugs Forum. Could you tell us a wee bit about the Scottish Drug Forum and what it is you do, please?
Sure, yeah. So SDF's been around now. This is our 40th year. It's our 40th anniversary. It's crazy. I've been with the organisation for 14 years, which is scary to say out loud. But we, I guess in probably the simplest way to describe us in one sentence would be that we're a drugs policy charity. So we're seen as a national resource expertise on drug-related issues, and we have a number of different programmes based within the organisation. So I think when I joined SDF, we had about 20 staff, and at the moment there's around 45. So it's grown quite a bit, but the third sector goes in peaks and troughs in terms of numbers. But the main bits of work that we do can be confined into three different headers, really. So we have a knowledge exchange element to the work that we do. So that'd be sharing information. We're membership-based organisations, so we do consultations. We have conferences. We have webinars, sharing international examples of good practice. And we deliver a lot of training as well. So we've got a workforce development stream to the organisation for the sector. And that also includes the national traineeship, which you might be familiar with, that puts people with a history of substance use or current substance use through an SVQ and gets people jobs in the sector. And then a whole strand of work around lived and living experience, which I'm sure we can talk about a bit more as we go through. But basically everything that we're doing is trying to reduce harm for people who use substances and improve Scotland's response to drug-related issues.
Amazing. And you're right, we're going to speak a lot more depth of that earlier. Can you give us a wee bit of background yourself? How did you end up at the SDF? What's been your kind of career path?
Yeah, I mean, early on in my career life, I didn't have a clue what I wanted to do. I went through all sorts of different random jobs before deciding that I wanted to do my mental health nurse training. So I did that, and following the completion of that, worked in the acute mental health ward in the local area that I was living in, and really got an interest in working with people who use substances through that work. Because we had beds set aside for people to come in to detox or for a bit of stabilisation or to start prescriptions. And then following that, worked in the community addictions team.
Okay.
And I was in the community addictions team where the national Naloxone programme was introduced, so I became the local lead for that. And then a job opened up at Scottish Drugs Forum, which led nicely and naturally into that bit of work as well. But I do think that a lot of that early work, working directly with people who use substances, has really shaped how I work today and the thoughts that I have about where we're at in Scotland and what needs to change. And it was quite, it was quite tricky in the area that I worked in, because a lot of the people who use substances and who would benefit from our services were also people who I'd grown up with, who I'd gone to school with, and our paths had taken very different turns. And, saw a lot of devastation through that as well, in terms of the loss of life locally, and really always felt this real desire to want to help people. And I think that's featured coming into this role as well.
Brilliant. And you spoke there a bit about Naloxone there, and if you think back to when that was first launched and you were involved in it back then, How far have we came with naloxone over the years here in Scotland, do you feel?
Yeah, it's been a particularly successful introduction of a national programme in Scotland. So, we'd been, before my time, Scottish Drugs Forum had been advocating for naloxone provision to be made available because of the rise in numbers of drug deaths. Now, that was when we were seeing 300-400 deaths per year. And if you think where we're at now, sadly, over 1,000 people dying of preventable deaths every year. It's horrific. And SDF took guidance from other countries that had introduced it. So the Chicago Recovery Alliance had been a big founder for naloxone provision. And that information was used to shape propositions for Scotland to roll out. And, at that time when it was introduced, I was working in the community addiction team. I remember getting our training from SDF actually, and our whole organisation being really bought into delivering this as part of the work that we were doing. But I think for me, it was only when I started providing it that I really truly bought into the idea of it, because I went out on the first day that I had been trained. I went out with my little kit. I chuffed with myself that I'd done this new training, had my naloxone kits in my bag and all my paperwork, and I had the clients that I was seeing that day, and I was like, right, I'm going to train everybody today, get them all carrying naloxone. So we just delivered it in short, brief interventions with people. And I remember one guy coming in and I said, I've just done this training. I'm really excited about it and what it could mean for us locally, and talked to him about what the medication was, gave him some training on how to use it. I mean, it's like 15 minutes. So he was up for it. Went away with his kit. And the next week when I saw him, he came back into the clinic and I asked him if he was still carrying it. And he was like, oh, I need another one because I've used it. And I was like, you've used it? What did you use it on? I had no idea that it would have such immediate impact. So basically what had happened was there was somebody walking past his flat. He lived on a ground floor flat. It was his mate. He'd shouted his mate in. They both used together. The mate overdosed in his house, and he had his naloxone there, and he used the naloxone on him to potentially save that guy's life. And I was honestly astounded, but it gave me so much satisfaction to think that we'd been able to show people with actions rather than words that their lives mattered, and that we were able to provide them with a piece of equipment that could make a real difference to their lives or to their friends' lives as well. So we became the best providing, not that it was a competition or anything, but we really ran with it. We were the best, yeah. So our area really, we were able to see how many other kits were being supplied across the country, and we used that to help boost our supplies and stuff as well. Give a bit of healthy competition to make sure that we were providing it to everybody that we possibly could as well was great, and it was really successful. Yeah,
and it's just amazing. You hear the stories of actual examples like that, isn't it, where that was used. And I was really surprised. I think it was only a few years ago that I heard emergency services didn't carry naloxone. How did that come about, and has that changed now?
Yeah, so ambulance services have always carried their own naloxone to use in emergency, but through the Drug Deaths Task Force that was introduced several years back now, we brought on board the ambulance service to actually supply kits to people. So if they were attending a near-fatal overdose and they had administered naloxone to somebody, they were also now able to supply it to that person and to the people who'd witnessed it. So that's been really successful, and it's not a lot of countries that do that. So it's, great that Scotland have developed different models like that. And, I think some of the critique that the naloxone programme gets is, you're spending all this money on naloxone and, drug deaths haven't dramatically reduced. And I think the concern is that if we didn't have such high levels of naloxone distributed, that our numbers of drug-related deaths would undoubtedly be even higher, which is horrendous to think about, but it should be a core part of any overdose prevention strategy. So any avenues that we're able to see for it its provision through the ambulance service, people working in services, anywhere that we can get it out is so important. And now, of course, we've got things like the Scottish families affected by alcohol and drugs provide the national click and deliver service, which is amazing. But the priority of the naloxone programme always has to be to get it in the hands of the people who are most likely to witness an overdose, which is people who use drugs. And we should not forget that.
No, totally. And we also kind of have that as well. I think it was you came up and visited Abigail, and we were kind of providing to people who took opiates and their families and stuff. And we spoke. I think you mentioned that about like, give everyone, all the clients coming through. So we've managed to increase that as well, because it's like you were speaking there. It's going to be people that's alongside other people, isn't it, that are using opiates is going to be able to use that. Do we have numbers regarding overdoses saved by naloxone? Is that something that gets tracked?
It's a bit harder to get the information from. I mean, what we do is whenever somebody gets a repeat supply in naloxone, they're asked the question about why they need it. And one of the reasons is because they've used it on somebody else. So we're able to collect some information that way, but I think it'll be so underreported because people may not disclose that they've used it, or they might just not think to report it, and we don't have systems really in place that properly capture that level of information. So most of it that we hear is anecdotal stories, and people sharing their experiences of using it or having it used on them as well. And family members, of course, as well are a key part of that. And you're right to highlight that it's not, whilst we absolutely want to get it primarily in the hands of people who are using substances, other people who are likely to witness an overdose are family members, friends, who might just well be on the scene. And a few years back, we did a national awareness raising campaign so that we were really getting people to think about their own personal circumstances. Are you living in an area where you might well come across an overdose? Because you just never know where you might have the opportunity to save somebody's life.
Well, thank you. And just kind of on those kind of areas as well. So you spoke there about going for a few hundred drug deaths here in Scotland to increasing over the years. What reasons have we seen this? What changes have we seen in the drugs in the streets of Scotland at the moment? Is there anything significantly changed that could be a factor in these deaths?
Yeah, it's always the key question, isn't it, about why Scotland? Why Scotland got these high rates? And I think the reason that we never get a straightforward answer is because there isn't one. It's like such a combination of loads of different factors. We know that people who are dying are in the highest deprivation areas in Scotland, so they're more likely to be experiencing poverty, deprivation. We know the links with trauma, lack of opportunity and all of that. But also in Scotland, we are known for using large combinations of different drugs, and we've talked about the majority of those being depressant type drugs, downers, and large combinations of that, and people also not knowing what they're using. And I'm sure we'll talk about some of the different trends and what we're seeing now in terms of the new substances that are more toxic and more risky for people to be using. And the other key thing that is a bit of a standout for us in Scotland is we always talk about treatment being a protective factor. And generally when we're talking about treatment being a protective factor, most of the evidence is pointing at prescribed treatment. So like people being on a prescription or an opioid replacement therapy, particularly when it's opioid dependence that is the main driver for the deaths. But the people accessing the treatment that could potentially save their lives, the rates are much lower in Scotland than they are in other parts of the world. So we really need to be looking at our treatment service and what the barriers are for people engaging in services that could potentially save their lives.
Yeah. So I know the SDF have a very kind of positive kind of scheme regarding not just lived experience but living experience. Are we getting these answers from people with living experience about why they might not access services here in Scotland?
Yeah, so something that we've has always been a core value of ours is making sure that we're getting information from people who are at the highest risk, which is people who are currently dependent on the substances that are causing the deaths. So we do that in a variety of different ways, and that could be through our peer research work, where we're interviewing people who are accessing services or in need of services. Or it could be through our new living experience engagement groups, which has been a fascinating project over the last 5 years through funds through the National Mission on Drugs from government. And that's enabled us to set up groups in local areas across Scotland of people who are currently using substances to come to these groups and share what matters most to them locally. And they bring the agenda, they decide what's being discussed, and sometimes that can be what drugs are becoming available, what effects they're getting from the different substances, what problems they're having access in treatment, what the issues might be locally in terms of mental health support. And that really helps us paint a bit of a picture about what the reality is for people. And that's so important that we listen to people who are currently using substances in terms of being able to make improvements locally. We encourage people, in the absence of Scotland yet having drug checking services, we've been encouraging people to send off samples to the Welsh service, Weddinos. And that, takes a bit longer. It takes a few days for people to discover what's in their drugs, but it's given us an indication of the changing patterns, the emerging substances, what people are buying, or they think they're about to use versus what's actually in a substance. So that's been really helpful as well, and to have their experiences noted is really useful. One of the key things that people are telling us at the moment about what's an issue is with our current service provision is that it's very opioid focused, and we know that there are more and more people using cocaine and crack cocaine. So the general sense for the groups seems to be that people will be using both, so they'll be using cocaine and opiates. And they know that the services would be able to support them with their opiate use. But because that's such a small part of their drug use, they're almost telling us that it's pointless going because they know that nothing will happen for their stimulant use. Okay. So we're not adapting our services quickly enough to respond to the changing trends in drug use.
So this is something that's been quite common in Scotland maybe the last 10, 15 years, isn't it? Cocaine use, crack cocaine use, a bit of an epidemic when it came. What treatment is there available to deal with cocaine?
So there are no current prescribing options that we offer in Scotland in the same way that we would do with opiates. So even that, the options are limited for people who use heroin and other opiates in terms of there just being one or two different prescriptions, so methadone or buprenorphine being the main two. And for cocaine, there isn't that option here. There is in other countries, so there are some examples of good practice in other countries for providing stimulants and substitute prescribing. But I think what we've forgotten is that other stuff that we can do to support people is really valuable. So there's harm reduction advice that we can be giving people. There's the wider wraparound supports that can be on offer. And it's almost become like our services are too opiate focused. So people don't use them, but then staff also are not encouraged to think more broadly about what they could be offering to people. I think that's where our third sector services often come into their own, where they're able to provide a lot more of the harm reduction support without the prescribing. But yeah, I think that's a big gap in terms of the things that we can do to support people looking at their lives more holistically rather than just focusing on the substances that people might be using.
Have we seen a lot more drug harems since the kind of cocaine kind of epidemic, maybe over the last decade, a decade and a half? Because unlike opiates, there's more people injecting more often and sharing, injecting kind of tools and stuff like that together. Is that something that we're seeing, and are we dealing with that?
Yeah, I think it's a good point. Like, if we look back to 2015, probably one of the biggest harms that we saw through injecting cocaine was the HIV outbreak in Glasgow. So, and exactly for the reasons that you're talking about, there's more injecting, there was more sharing of equipment, and that was something that came out strongly from the health needs assessment that they did in Glasgow. Cocaine use being a key driver for the increase in HIV diagnoses. And also the wounds that we've seen from people injecting more frequently, not just through cocaine use, but through some of the new substances that are emerging as well. Different benzodiazepines, a new substance called xylazine now as well. All these frequent injecting patterns, sharing of equipment, sharing in some or using in some of the most undignified conditions that are really unhygienic and really risky, adding to that risk of infection as well. Plus, on the back of that, people feeling stigmatised by services. So, you know, it shouldn't be the case that somebody's leg's almost fallen off because of a drug-related injecting wound before they actually think to go to a health service. You know, why is it that people are reaching that phase before they're actually seeking help? And of course, a big driver for that is stigma and how people know they'll be treated by health services. So there's a lot of work that we still need to do to stop discriminating against people who use drugs as well.
Yeah, so we touched on there regarding the kind of the outbreak of HIV in Glasgow 2015, then there was a large push there then, wasn't there, for a safe consumption room, and last year it opened, was it?
Yeah, it's just over a year. Yeah.
Just opened a year there, and what kind of outcomes have we seen, or what benefits have we seen since that opened regarding, I know it's very early to get outcomes, isn't it, as such, but what benefits have we seen the services given Glasgow?
Yeah, so I remember those times and that health needs assessment being done. It was published in 2016 and it had a number of recommendations for improvements that were required to address the issue. And two of the recommendations were for new services, one for a safer consumption facility and one for a heroin-assisted treatment programme. And of course, the heroin-assisted treatment, which is called the Enhanced Drug Treatment Service, was introduced several years ago now. But there were more legal blockers for the consumption facility. So that's taken an incredible amount of time to actually roll out something, or to introduce something, I should say, that has had international recognition of being cost-effective, evidence-based and life-saving service in other countries since the 80s. So it's unfortunate it took us so long. Very glad to see it finally there. So Glasgow opened the first facility in January 2025, just over a year in, and you're right that there is an independent evaluation of the facility happening, so that will start to shine a light on some of the improvements that have been noted from that service being in existence. But I think just from being involved in seeing the service develop, some of the clear benefits and what people who use substances are telling us is that they have a space where they can attend regardless of how they turn up, having without judgment, a compassionate approach to their substance use, feeling valued as a human being, feeling like people have got their back, that they can use their substances in an environment that is completely non-judgmental, that is not pushing them in any particular direction, but is just there to support, to provide people with options, and to meet people unconditionally where they're at. And I think that's the absolute beauty of the service. People don't necessarily for the first time go in and inject drugs. People have been going in to use the showers or to use the clothing facility or to just have a chat with staff to suss out, what the staff are like and how they'll be treated. And, to have that space is invaluable. Like, it's taken us so long to get it. It's been really sad to see some of the critique around the service, particularly where people are being linked into interventions that are creating positive change for them in their lives. That might be getting into treatment. That might be making links back with their families. That might be getting their housing sorted. It might be getting their benefits addressed. A whole range of different improvements that are being introduced for people. I think what we do want to see in Scotland, though, is that we want to see these rolled out in any area where the alternative for people is injecting in a close or somewhere extremely unsafe, and that we can introduce loads of different types of models. So it's not just this model that we could use across Scotland. So there are a variety of options: mobile units, fixed sites, third sector ran, peer-led facilities. All of these should be on the table. I would like to see us get to a point where any service that's providing injecting equipment would also be able to provide a space for people to use in safe conditions, so that the alternative for people going outdoors and then into the close and being discovered some hours later having had an overdose does not occur, and that people are treated with that respect.
When you were speaking there about the kind of feedback from the people that use consumption rooms, and you're speaking about they get treated non-judgemental, they get treated with dignity, shouldn't that be every service across Scotland, the world, when you arrive there? So it's why are they feeling different walking into other services would be my question.
Well, it's such a key point, isn't it? Like, because I think what this service has done, because there are no conditions attached to its use other than you appear as you are, quite a lot of our other services don't take that approach, and there will be conditions attached to your engagement. So don't turn up intoxicated, don't turn up this, don't turn up like that, or like even the design of our services can be really off-putting for people. We still have the situation where people go to pharmacies and they're standing in separate queues, or they're having to go to a hatch in the wall. These are not trauma-informed environments. So I think what the Thistle service in Glasgow has done is really shine a light on what a trauma-informed service should look like. So that comes down to even the basics, like how welcome do you feel when you walk into a place? Mm-hmm. What's the furniture like? What's the general vibe and the sense of, respect when you walk into a building? Is the place falling to bits? Mm-hmm. Or is it kept really well? Is it clean? Is it tidy? Mm-hmm. And all of these things make a difference to how people are perceiving themselves as well. So I think there's probably a lot to learn across all of our other services about that culture that they've managed to create in the Thistle, that could absolutely be replicated across other services and should be, but it requires the right staff, the right attitudes, the right values, and crucially the right support for staff as well, because staff that are not having their own well-being prioritised are not going to be performing at their best in terms of how they're treating people who are accessing their services. So there's a whole range of things that we need to be considering to make our services as inclusive as the Thistle has managed to do for their people as well.
Yeah, and what we know so far about the Thistle, there was a number given, wasn't there, the amount of non-fatal overdoses that took place at the reversed in there with the use of Naloxone in the first year. Do you remember what that figure was? Yeah,
so there's a small number. I mean, they have a small number of what they would class as medical emergencies every month. And some of these incidents will require them to call an ambulance, but most of them don't, because these overdoses can be managed. And I think that's the real crux with overdose emergencies, that if there's somebody there, people don't have to die from an overdose. And they won't always have used naloxone on those interventions as well, so they'll be able to intervene with oxygen, or they can see people deteriorating, so they'll be able to apply oxygen. If they need to, they can use naloxone, and in some circumstances, if there was complications, they would need to call an ambulance. But most of those are managed really well by the staff having the training and being able to respond immediately when they notice that there's an issue.
Yep. So the opening of the safe consumption rooms was big news in Scotland, wasn't it? It was big news, and there was kind of mixed reviews of it and mixed concerns regarding, like any kind of drug service, you know, when you open up a rehab, the general public think people's going to be using drugs there, and it's the exact opposite and stuff like that as well. How has society embraced it, or are people still kind of cautious of the service?
Yeah, it's a shame because there has been a lot of negative media attention on the facility. I mean, when the announcement was made, there wasn't so much negative media, which has been an interesting journey to watch. So it was very difficult at the time when it was announced to find people that were really speaking out against this approach because of how these facilities have been rolled out internationally, the evidence behind them, and just the clear need. I mean, it was described in Scotland as one of the most compelling cases in Europe for a safer consumption facility. So I think people agreed initially with the premise. However, where the service has been introduced is in an area that's had decades of lack of investment and decades of problematic drug use in the area. So discarded injecting equipment, people injecting in areas like in bin sheds and local residence areas. But that's not because of the consumption facility. That existed well before this service was introduced. So across the globe, these services are placed in areas where there's already dealing happening, there's already drug use happening, so that they're right in the centre of where they can help with the issue. And that was exactly what happened with the placement of this facility as well. But unfortunately, over the last few years, there's been a lot more attention on the issue of drugs, which has been good because it's been described as a public health emergency. But because people are passionate about this area, sometimes that passion can become divisive, and we can see people pushing forward particular approaches and not being so supportive of a harm reduction and a wider approach, and having a narrower focus around abstinence and residential rehab. So almost this service has been used as a bit of a political football in terms of those two different ideas and approaches. So there's been a lot of work done with the local residents to try and increase the awareness about what the service is there to do, responding to local concerns, because of course there's concerns for local people. Who would want to be walking out of the place that they live and having to respond to an overdose in their close as well, and having the trauma of people potentially dying in and around the place that they live? So we don't want that for anyone, and we certainly don't want people who use drugs having to face using in environments like that either. So there's been a lot of critique on the service. I think the evidence will speak for itself as the service begins to embed itself more thoroughly. This has been the case internationally when new services like this have been introduced, that originally you get a lot of public discontent. But I would really hope that we can start to see real benefits for the locality as well as the people using the service in years to come.
So I understand the kind of issues in that area where the service is. Are we seeing any benefits in other areas? Is there any feedback regarding benefits of other areas where maybe these drug users would be using usually, but now they're using the safe consumption room?
Yeah, I mean, there's much less discarded injecting equipment around, but I mean, one consumption facility in one particular area in Glasgow is not going to be suitable for people using across the city. So hence why we need multiple options for people. People aren't going to travel with their drugs to go and use them in an area, anything that's more than a 10-15 minute walk is probably not going to be utilised. Hence why they need to be placed in the areas that are already affected or that people are already using in. I think it makes the case itself for why we need multiple models.
In the kind of planning of the safe consumption rooms, when we speak about kind of decriminalisation of possession for people who are going to use the service or in that area, was there a lot of discussions with police regarding that being a kind of zone where you wouldn't stop and search people? Or what is the kind of the legal aspect there?
Yeah, so I mean, people listening might remember you might remember it yourself, Eddie, when the proposal was originally put in place to have this, we had a different Lord Advocate than we've just had just now. And there was a proposal put in because there's a legal issue with the Misuse of Drugs Act being reserved to Westminster and Scotland not being in a position to change things that are in that act. So when a proposal originally went to the Lord Advocate in Scotland, who's the Chief Legal Officer, who can make the provision for things, so the Lord Advocate was responsible back in the day for enabling needle exchange programmes to run, more recently for wider naloxone provision during COVID, so we were able to open up some avenues around that. And also for possession of any substance being subject to a recorded police warning rather than a prosecution. These are all things that the Lord Advocate can introduce and has. But at that time, when the proposal went into the Lord Advocate to ask for permission to run this service, that current Lord Advocate said it wasn't within their jurisdiction and that it needed to be a change to the Misuse of Drugs Act. So that left us really in limbo again, unable to progress the service, which was really disappointing. SDF as an organisation fully believed that it was within the gift of the Lord Advocate to be able to make this change. So we got a new Lord Advocate, and the proposal was put in again to this new Lord Advocate, and they did feel that they could put in what they call a statement of prosecution policy, which was very clear that it wouldn't be within the public interest to prosecute anyone who was using that facility in possession of drugs for their own personal use. So there is no exclusion zone, sort of safety zone outside the facility. So I think there was this myth that people could be dealing drugs immediately outside the facility and that would be allowed. That's not the case. It's literally only within the footprint of the facility that people could be in possession of drugs to use under supervision. So normal policing can continue, but of course there needed to be work with police, because the last thing we wanted was a lineup of police stopping people who were trying to enter the facility. So similar to what happened with needle exchanges back in the day, there had to be that acknowledgement for police that this was a public health approach and that they wouldn't intervene unnecessarily to prevent people from using the service, and that's how the service has been operating.
Yeah, because you always think that could be a big kind of block for people to walk the streets with drugs, towards here, and likely to get stopped. Where are we at in Scotland regarding the decriminalisation of possession of drugs for people who are dependent on substances? Is that something that we're pushing for? Is that something that we believe?
Yeah, so there's probably a few things to that. So it was in a previous government policy position. This government's policy position over the last couple of years, they produced a paper about a compassionate response to drugs policy in Scotland. And that included in there about a move to decriminalisation, was supported by global networks. But we've not moved anywhere towards that direction. I guess the slight shift was the policy change made by the Lord Advocate, the one that I've just mentioned about recorded police warnings being available for small amounts of possession for any class of substance, which only used to be Class C, and then it's now for any class. So, but we don't have good reporting or data about how that's being delivered in practice, and we've got varying stories from people who use substances about their experiences of that as well. So we could really do to understand better whether that policy's had an impact on the people that we would want it to, and that it's having a positive impact. But you know, all of these policy interventions and practice changes can only go so far in terms of challenge and stigma when we continue to criminalise people for their drug use. We wonder why we've got a drug problem in prisons when we continually send people who use drugs to prison. So there has to be a sensible strategy around why is it that we think it's okay to continue to criminalise people for their drug use when we know what the drivers are for drug dependence. So we would be very supportive of strategies. It's in our manifesto that we want to see a move towards decriminalisation. Further than that, we probably want to see a move towards what regulation would look like. So, you know, I would like to see these conversations happening in the future about, you know, decrim can take us so far, but what would a regulated market do in terms of reducing the risks of adulterated substances, particularly now when we see nitazines, xylazine and more toxic substances coming into the market and people have no idea what it is that they're using, no quality control, no way to reduce their use based on what it is in the substances, because people just don't know. So there's no autonomy over their drug use and no way of them making informed decisions about what drugs they're currently using.
And I think it's always going to kind of face debate, isn't it? You know, other side of the coin is we can't just have free rein where drugs are used freely and maybe end up with more people end up dependent on it, you know. So what is the thinking there when people come back like that around about kind of decriminalising drugs? What the families think, you know, when their sons and daughters are using substances and they're maybe being provided with drugs, or, you know what I mean? It's quite hard for people to get their head around. Would it be people who are accessing services who are kind of maybe registered with a service and non-drug users that maybe that would take place? What does that look like?
I mean, I think we don't know what it would look like for Scotland because we've not properly explored it. And I think all of these things have to be on the table, and completely appreciate what people's concerns would be when it's the unknown. There's a family organisation, Anyone's Child, that heavily campaigns for regulation, and that's based on their own losses and what they've seen and what they feel would have helped also their family members just to know what it was that they were taking, and it would open up routes for more education and, you know, treating people like adults and giving people autonomy over their own choices. And it may well be that something like a regulation model might encourage isn't the word that I want to use, but it might open up avenues for people to use substances that might not have before because they were concerned. But surely that would still be a safer way of doing it. I don't think we'll ever get to a point where people don't use drugs. There will always be people who use substances, and the core goal of organisations like ours has to be about, if that's the case and that's the reality, how can we make sure that people don't die from their choices and from the circumstances that they're in, and how do we help reduce those risks for people? So all options should be on the table, and we can't just rule strategies out or policies out or practice out because it makes us feel uncomfortable. We need to look at these in an informed way.
Where do you think the line is between reducing harms with drug users and enabling drug use? Where do you think that is?
Yeah, I mean, the enabling word is a controversial one.
Well,
And
let me kind of speak a wee bit more round about giving people a space like the safe consumption rooms. And it kind of contradicts it, doesn't it? A safe consumption room for people who's going to use drugs anyway, and enabling. But maybe places like that where, okay, we understand you use drugs, we want you to do that as safe as possible, but also here's a building here where you can come and do that.
yeah.
What is the difference there between somebody's using drugs and we're going to try and help them keep as safe as possible, we'll make sure they've got company, we'll make sure they've got clean tools, clean paraphernalia and stuff like that, to, well, here's a building that you can come and use drugs. Do you know what I mean? I'm just saying it from a very...
Yeah, no, and I think it's a question on a lot of people's minds. For me, it's about enabling hope and enabling positive change and enabling people to feel worthy of support. Because you provide an environment like that people are not used to. People will attend with really low self-esteem, probably really low sense of hope for the future. And actually, by showing human kindness and accepting people where they're at unconditionally, can be the catalyst that opens up their thinking to what else is there out there for me. So rather than, I think some of the critique is about these types of facilities keeping people static in that holding place of using drugs, and that's absolutely not what the premise of it is. It's creating a space where people feel okay to be themselves, and to explore the opportunities and the possibilities for them going forward in the future. So hence why there is such success. The evidence is really clear that the more somebody attends a facility like that, the more likely they are to go on and make positive changes in their lives. And that's key to that human connection and hope and people believing in you. And I think that's what these facilities provide, rather than keeping people stuck, or I think stigma keeps people stuck more than any sort of provision like that does.
So I know you've been to a lot of places over the world to practice different kind of forms of harm reduction, some way ahead of where we're at in Scotland. Where do you think, what areas use the best models that you've seen with the best outcomes, and the systems seem to work really well? What does that look like, and where would that be?
Yeah, I don't think any country has got it right completely. I think there are examples of good practice in loads of different countries and loads of different ways that I would like to see us introducing things in Scotland. So some areas like the Netherlands, for instance, have got, rolled out loads of different types of service provision. Have been doing it way longer than any other countries. Countries like Switzerland, where they have really embraced harm reduction at its core, have seen successes in terms of the treatment for people who use substances. Then you've got like Portugal, who decriminalised people, and you've got pockets of that sort of happening. Every time I say pockets now, it makes me cringe because it's because it's been highlighted to me as one of those words. So it's now sitting in my bank of words like silver bullet, pockets, all of those. Yeah, so forget I said that. But small examples of practice that would be really useful if one country just brought all those together into one approach. So, and I think that's always the problem. We see examples of that, but we would really like Scotland to be the innovation. So bring all those approaches together, roll them out across the country. Then, if we had the proper infrastructure to support people, decriminalised people, had drug checking everywhere, had safer consumption facilities rolled out, had Naloxone everywhere, had really accessible, acceptable, inclusive, equitable drug treatment, had all the abstinence-based approaches available for people when they want them. If we had all of that in the one country, it wouldn't matter what new substances emerged because we would have the right supports in place for people. So, yeah, I think countries have done different approaches when it comes to opening up cross-government opportunities. We still quite siloed in Scotland, with drugs being quite a separate part of government, where we would want to see that embedded into all portfolio areas in government, like justice, housing, mental health, employability, all of the areas. So it wasn't just sitting alone. So that it had that inclusive approach and policies that are not subject to parliamentary cycles either, so that we're looking more upstream and being able to address things like poverty, deprivation, trauma, lack of opportunity, and all of these things. Otherwise, we're always going to be firefighting.
Yeah. So what would you like to see happening in Scotland for the future, or what plans is there for the near future regarding reducing harms and helping people who are addicted to substances?
Yeah. So internationally, Scotland is seen as quite progressive in terms of its drugs policy approach. For people in Scotland, it probably doesn't feel like that, because there is still this gap in terms of implementation. So it's all very well something being written down on a policy, but actually putting it into practice is one of the key issues. So really, we would want to see all of the things that are being highlighted, proposed, that are policy, being actioned, so being properly resourced, being properly actioned, and the right supports in place to enable that to happen. We want to see that upstream strategy, and that there is more focus on what happens for sort of earlier years stuff to, I guess, identify trauma earlier, be able to support people at a much younger age, being able to educate people in a better way, and also to be addressing poverty, deprivation, and all the other drivers. We want to see people decriminalised for their drug use. We'd like to see major changes to the Misuse of Drugs Act to fully enable a public health approach. So there are certain areas of the Misuse of Drugs Act that could be devolved to Scotland, particularly around the licensing issues that we have for drug checking services, to make that a smoother process. Getting rid of Section 9A, which is the one that talks about what equipment we can provide to people. That's quite restrictive. I mean, we've got so many people using crack cocaine and a ridiculous law in place that doesn't allow us to provide people with safer inhalation devices. This is just incredible to still be in that position. So we would see Section 9A being removed. So yeah, changes to that's preventing us from fully embracing the public health response that we want. Proper investment as well in alcohol, harm reduction and alcohol treatment, so that there is a balance there, because most people who use substances also use alcohol as well. So, if we're going to have the two strategies in one, which has been announced actually today while we're recording this. The strategy's been published. It's a drug and alcohol strategy, but that needs to come with more resourcing as well. We can't just spread it even more thinly across both. Just interrupt me if I'm going on too long, but we want to see improvements to the support of the workforce. So that people, like we talked about earlier, are fully supported, that we're not burning out the workforce that we're expecting to help support people who are in really difficult circumstances. There was a lot of work over the last few years on the Charter of Rights, the first of its kind, a Charter of Rights for people who use substances. We want to see the Human Rights Bill introduced in Scotland and that being more formally linked to that. But we want to see that being embraced locally across Scotland, so that people know what their rights are and that their rights are being adhered to. That is a big part of the work. And across all of this, we can't produce any policies, introduce any new services or any new practice without the full meaningful involvement of people who will use these services or be most affected by these policies. People who are at the closest risk of death from policies not being implemented properly, and that is people who are currently using substances. So they have to be involved in the shaping of services, the design of services, not brought in at the last stage to say, what do you think about this thing that we're proposing, but involved from the very beginning of the shaping of it. I mean, a great example of this was earlier this year, where we had real risk in a few local areas from the introduction of nitazene, so really potent opioids, much more powerful than the heroin that people have been used to. And there were public health consultants involved. There was groups pulled together to look at incident management around all of this. And none of these groups had people who use substances as part of those groups, which I just find incredible. That how could we possibly fully understand what the picture is without formally involving people who use substances? So that's something that we're really keen to see better implemented across Scotland too.
So a lot,
just a few things,
a lot of areas to look at. Thank you so much, Kirsten, for coming on Listen Up podcast today. It's been great spending time with you, and really interesting to hearing about the work you do at the SDF and what you're looking to do in the future. I asked you earlier if you could think of a song, a significant song in your life that meant something to you. Did you manage to think of one?
So just for the listeners' knowledge, this was sprung on me right as we were about to sit down. And it's probably the question that I've been most unsure about how to answer. All of those other questions were fine, probably more complex, but I can't think of a particular song, right? But I'm going to let you into an insight into my listening, what might be on a Spotify playlist for me, right? So I am a massive country fan.
I think I've heard this before. I think so.
I don't know where I might have disclosed that.
No.
So I have all these country playlists, and I honestly find like some of the lyrics very fitting in terms of these country and Western songs. So don't be surprised if you were to jump into my car at some point and find a country playlist. So keeps me motivated. Some of the wording in some of these songs. Maybe I'll try and find some essential here.
No, thank you so much, Kirsten. And as I said, thank you for coming on and being a guest today. And I'll speak to you soon.
Thanks, Eddie. Cheers.
Thank you.